Thank you everyone for joining my presentation. My project title is Using Linked Health Service Data in the Evaluation of Innovative Models of Healthcare. Before I start, I would like to acknowledge all the co-authors for their support and contribution in this project. Let's look at some background and aim. Hospital readmissions, particularly amongst people with chronic complex conditions, are expensive and in many cases preventable. The Victorian Department of Health and Human Services implemented a trial of a program to try and reduce the risk of the readmissions in people deemed at high risk of rehospitalization. So this project used linked electronic medical records data to evaluate a pilot community-based model of care to reduce hospital presentations in a cohort of patients at risk of hospital representations following an acute admission. Methodology. In selecting participants, a hospital readmission risk score developed by the SARO and provided to health services by the state government was used to identify eligible people. Those admitted to the main site of Peninsular Health with a non-surgical conditions and a readmission risk score equals to or greater than 9 were eligible. Additional eligibility criteria were also applied, but I only mentioned those applied to the intervention group here. The intervention group received care navigation. Care navigation's interventions consist of a minimum of 4 phone contacts to each patient for 1 month post-discharge. A registered nurse rang patients within 3 days after the hospital discharge and then provided weekly follow-up for 4 weeks to organize the medical appointments and other healthcare needs. So we measured time to first readmissions at 30, 60, and 90 days. So how do we identify the people for intervention? State hospital data were used to apply a readmission risk prediction algorithm to group patients admitted to the main site at Peninsular Health between May to November 2017. The algorithm includes patients' age and residency, presence of unplanned admissions and ED visits, chronic conditions and smoking status. It excludes patients who are less than 17 years of age, who have active cancer, who are on palliative care management and certain non-curable chronic conditions requiring regular planned hospital admission. So patients whose score equals to or above a threshold value of 9, based on the previous 6 months of the state hospital data, were deemed to be part of the total eligible patient cohort for the purposes of commencing the trial. So in terms of selecting the comparison group, propensity score matching with bootstrapping and weighting was used to randomly select 5 people admitted during the same time period to compare with each index case matched on the following variables. A propensity score was calculated based on the age, sex, readmission risk score, ERSET, living arrangement, previous hospital admission in the past 12 months, any weekend hospital presentation, any previous surgery and comorbidities, particularly chronic heart failure and chronic respiratory disease. The index event for cases was the admission where they received the interventions, whereas the index event for comparison group was the admission at which they became eligible for the interventions. That is when the readmission risk score equals to or greater than 9. Statistical analysis. Descriptive analyses were used to compare group characteristics and describe outpatient attendances. Logistic regressions was run to derive the propensity score. Multivariable cost proportional hazard regressions was used to compare time to readmissions, and the models were adjusted for confounders not included in the matching. So let's have a look at the results. This is a descriptive analysis of 2 groups. This is a very busy slide. So mainly we can group them into 3 columns of information. We can see the left-hand column shows the covariates included in the propensity score matching model that I mentioned before, but actually in more details. So before matching, the column in the middle, the two groups were quite different. Most of the standardized difference were greater than 0.1, except the sex variable. 63 patients received interventions were matched with 262 controls. After matching, which is the right-hand side column, the cases and controls became similar. So this graph shows the distribution of the propensity scores before and after the matching. Propensity score matching with bootstrapping was used to isolate the influence of factors affecting readmission risk, improve internal validity, and reduce confounding by indications. The area under the curve of the logistic regression model used to derive the propensity score showed good predictive ability and reasonable matching, for the variables used in the propensity score was achieved between cases and controls. We also applied weighting when we ran the model. After matching, all covariates produced a standardized difference of less than 0.1, or the standardized percentage bias less than 10%. Standardized difference was used as it is a better way to look at differences between groups. Then we look at time to readmissions. These three graphs showed the time to readmissions at 30, 60, and 90 days from left to right. The darker line shows the time to readmissions of the intervention group, whereas the lighter line shows the controls. We can see the hazard ratio and the confidence intervals as well of each group. At 30 days post-discharge, the graphs on the left, whilst intervention has been delivered, we saw a large reduction, that is around 72% of readmission rate in the intervention group compared to controls. At 60 days, the middle graph there, the hazard was reduced to 65%. And at 90 days, which is the graph on the right, the hazard was reduced to 60%. All time to readmission showed good confidence intervals. Please note, all cost proportional hazard regressions models met the assumptions of proportional hazards. We also looked at health service utilization. Patients who received interventions had more scheduled medical and RI health outpatient appointments than controls during the 90 days post-discharge. Most of the patients in the intervention group had a follow-up medical appointment, so 66.7% versus 36.6% of controls. And a small proportion had an RI health appointment as well, 7.9% versus none in control. They're all scheduled within 90 days post-discharge. Where medical appointments were scheduled, attendance rates between the two groups were similar, both sitting above 80%. In conclusion, this pilot intervention showed promising results. The intensive phone follow-up for 1 month post-discharge produced a 72% reduction of hospital readmission at 30 days. It showed important clinical indications of reducing hospital readmissions, improving hospital service utilizations, and improving transition and support to patients, which allow them to better manage their health at home. This project also demonstrated the value of linked EMR data to guide clinical and policy decision-making and to inform hospital-wide service implementation using advanced statistical methods in the evaluation of real-world healthcare. I would like to acknowledge the community care team, the Health Links Steering Committee, and a few important staff members who support the project and data linkage processes. And thank you very much for listening.